Good morning, everyone. I'm Dr. Sridhar Santhanam, and I'm the professor in neonatology department at CMC Vellore. Over the next 30 to 40 minutes, we will have a talk on safety issues in the neonatal unit. My co-faculty for this session or this module are Mrs. Ebenezer Helen Benjamin, who's a professor and HOD of OBG nursing at CMC Vellore, Dr. Manish Kumar, who's my colleague and professor of neonatology, Mrs. Morris Shankar, who's the department manager of neonatal nursing, and Dr. Shanu Chandran, who's an assistant professor in neonatology department at CMC Vellore. We'll start off with the definition of patient safety. As you can see, the WHO defines patient safety as the absence of preventable harm to a patient during the process of healthcare and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum, which means that the patient does not suffer an injury or a morbidity or death because of the underlying condition for which he or she was admitted to the hospital, but rather because of something that happened during the time that the patient spent in the hospital. Alarmingly, it is estimated that 1 in 10 patients have adverse events related to the care given during stay in the hospital. And more than half of these, about 50 to 70% of these adverse events may be preventable. What happens if we do not ensure that the patient is safe during hospital stay? As you can understand, if the patient suffers any injury or harm during stay, it will increase the morbidity of the patient, it will increase death rates or mortality of the patient. Obviously, it will increase the length of hospital stay, and therefore there will be increased cost of investigations and further treatment because of the injury or adverse event suffered by the patient. Therefore, this imposes a financial constraint on not only the baby's parents, but also the health system and the hospital. As you can understand, if a newborn baby suffers any injury or adverse event during stay, there is a high risk that the hospital or the individual will be legally liable. But the problem does not end there. For a newborn, if a baby has a morbidity during stay and the baby gets discharged, that is not the end of the story, because many incidents that happen during the newborn period have the potential for causing long-term physical and neurological disability. All of you would have seen various news items saying babies die because incubators caught fire in hospital, or babies were abducted from the hospital, right? Doctors performed surgery on the wrong patient or on the wrong side or on the wrong organ. Babies were handed over to a different family than the family in which they were born, and therefore they were switched or swapped at birth, right? Wrong blood was transfused to a patient, leading to death, right? And the WHO estimates that healthcare or hospital-acquired infections is a huge number and accounts for nearly 2 million cases and about 40,000 deaths a year worldwide. There is another very alarming medical report, which may or may not be true, which says that in India, medical errors leads to death in nearly 5 million or 50 lakh patients a year, and this can be cut by 50%, right? You would have heard again about hospital fires, baby dies because nurses dropped the baby while handling the baby, etc. And there are innumerous news reports about such incidents which occur in the hospital, which compromises newborn safety. So how does a newborn's safety be compromised during stay in the neonatal unit? So adverse events in the neonatal unit may occur because of unsafe practices. This is mostly at an individual level, which is because of poor asepsis, unsafe blood transfusions, medication errors, unsafe medication use, etc. Unsafe processes where untrained doctors or nurses are allowed to handle newborn. There is wrong diagnosis, wrong treatment, etc. And a poor organizational culture. There are no protocols or guidelines, to manage newborn health. There is poor training of healthcare professionals, and there's a blame culture as opposed to a culture of nurturing and improvement. We're all humans, and therefore humans will always make mistakes. But errors in patient care are more often because of the failure of a system rather than the fault of one person. Let's take an example of a newborn baby being given a wrong medication or the wrong dosage of a medication, right? At first glance, it seems as if the nurse who gave the wrong medication or the wrong dose is the person at fault. But if you look down into the system, you may notice that this nurse, unfortunately that day, because of understaffing, is looking after 20 different babies. She's possibly the junior most nurse, has never handled a newborn baby before, has not been trained in actually estimating the dosage to be given to newborn babies, right? So there is not only a problem with by the individual nurse, but also problem in the system where she has not received adequate training and she should not have been, looking after that newborn baby, etc. Right. There's a very nice statement which says that nurses are the eyes and ears of the nursery or the neonatal unit, because they are there constantly 24 hours with the baby, and they will be able to recognize everything that happens to the newborn much before the doctor does. And therefore, a nurse has a vital role individually and as part of the team in ensuring safety of the newborn. What are the safe practices which can contribute to better newborn safety or newborn health? The first thing is ensuring that the newborn is properly identified, that we are identifying the correct newborn. Right? The next thing is preventing newborn abduction. It's not more an individual level, but it's something called code pink, which we will discuss as part of a process or as an organizational level. Right? Then preventing healthcare associated infections, that is HAIs, preventing injury of various types to the newborn, to give safe blood transfusions, to ensure safe surgery for the newborn, and to ensure medication safety and to minimize medication errors. We'll briefly go through all of these individually. A very vital thing is to properly identify a newborn. It is estimated that in a medium-sized or a large hospital, there are nearly 180 to 200 incidents per year where a baby is handed over to the wrong family or to the wrong mother. Fortunately, a majority of these are corrected much before the baby is actually discharged. Identification of the newborn is a bigger problem in India because the babies are not identified by a name and a surname, but rather as identified by the mother's name as Kavita's baby or Priya's baby, right? If you look at the 150 or 200 mothers and babies who are there in my hospital every day, you'll notice that there are multiple Kavitas and multiple Priyas, right? So it's very likely that if you're not identifying the correct Priya's baby or the correct Kavita's baby, the baby may be handed over to the wrong mother, or the baby may receive a wrong treatment which was to be given to another Kavita's baby or Priya's baby. This can also happen if there are twins or triplets. The wrong twin or the wrong triplet may receive treatment or may not receive the treatment which should have been given to the other sibling. Therefore, the commonest way or the best way of identification, possibly universally, which is seen, is identity bands at birth, which is a standard practice. There are some things which are essential to be noted in the identity band. The identity band of the baby should have the name and the hospital number of the baby. Not only that, it should have the mother's name and mother's hospital number also. Because it's not only important to identify this baby with this hospital number, but this baby has to be tagged or associated with the correct mother with that hospital number. And therefore, the minimum essential things should be the name and hospital number of the baby and the mother's hospital name and her hospital number. Ideally, the other things which should be there in the identity band should be the date of birth and the time of birth of the baby and the gender of the infant. This identity band should be attached to the ankle of the baby or above the elbow of the baby, and it should not be too tight. This is to ensure these areas are given to ensure that the identity band does not slip off the baby, and therefore the baby at any time is found without an identity band. There should also be a band around the hand of the mother. A very important thing to prevent switching of babies, because most identity bands are attached to the baby shortly after birth. But in a busy hospital, if many deliveries occur simultaneously, we should ensure that two babies who do not have an identity band should not be left in the same cradle in the labor room at the same time, right? One baby should have his or her identity band attached, and then only the next baby who's born just then should be put in that cradle, or the first baby should be removed before the second baby arrives at the cradle. Various hospitals use footprint cards, and nowadays there is a big thing for facial recognition, right? And also footprint, where the computer decides on the basis of an algorithm where it can actually identify babies according to their footprints. Footprint cards, though many hospitals, including my hospital, use footprint cards, they say that only about 20% correct identification can be done based on footprint card. It's more a record of the baby's footprints rather than a proper identification at the moment. The next very important thing to prevent or to ensure patient safety is prevention of healthcare associated infections. I think you would have had a major full module on prevention of sepsis. So I'm not going to go into too many details, but I'll just talk about the major points. I cannot emphasize enough on hand hygiene, hand hygiene, hand hygiene, hand hygiene, and that will take precedence over any other precautionary measure that we can take in the newborn nursery or the neonatal unit. We also always have to ensure that universal precautions are taken and standard precautions are taken when we handle newborn. There's another thing which I'm sure you may have touched upon in the sepsis prevention workshop, which is called the aseptic non-touch technique, ANTT. A few years back, when we had an outbreak of Acinetobacter sepsis in the nursery, we tried various techniques to try to get this epidemic to stop, right? Finally, we hit upon only the two basic methods of repeated hand hygiene workshops in small groups of nurses and doctors, and taking classes on aseptic non-touch technique, and ensuring that both these things happened very, very diligently. And that actually broke the outbreak. And therefore, these two things are very, very important in prevention of HAIs. There should always be a protocol for nursery cleaning. And as nurses, all of you would know that there should be a protocol for cleaning nursery equipment. This does not just ensure cleaning the major equipment like ventilators, incubators, etc., but the smaller and more vital things like suction jars, oxygen humidifiers, the tubing, etc. There should be protocols for safe disposal of medical waste, and we have to ensure that medical waste is disposed adequately. We should ensure antibiotic stewardship, and every hospital, ideally, especially tertiary hospitals, should have bundles for ventilator-associated pneumonia prevention bundle, CLABSI central line-associated bloodstream infection prevention bundle, etc. I'll just talk briefly again about ANTT, or aseptic non-touch technique. This has three major messages: correct hand hygiene principles. You have to protect what is called as the key parts at all times during the procedure using non-touch technique. And for every procedure, whether it's an NG tube insertion, whether it's an IV line insertion, whether it is an intubation, we have to identify which are the key parts which are there during these procedures and ensure that these are not touched. And there should be standard operating procedure and standardization of all these procedures. What is a key part? A key part are those parts or sites that, if contaminated with microorganism, will increase the risk of infection to the newborn baby. In IV therapy, this will be the parts of the equipment which come into direct contact with the liquid infusion or the patient. And therefore, this would be the portion of the skin where you're going to actually insert the cannula, the tip of the cannula, and the other end of the cannula where you're going to attach your three-way stopcock or your rubber bung. And these are the key parts here. And when you say non-touch, the principle is that you cannot infect or touch, you cannot infect a key part if it is not touched. And therefore, you have to ensure that the key parts in every procedure are not touched by the doctor or the nurse. And any key part must only come in contact with another key part. That is the syringe tip with the needle hub, the cannula tip with the skin at the point where you have identified that you're going to poke or you're going to insert the cannula. But non-key parts, the parts of the procedure which are not identified as key parts can be touched with confidence. And therefore, the principles of ANTT are ANTT, always wash hands effectively, never contaminate key parts, touch the non-key parts with confidence, and take the appropriate infective precautions. Again, briefly, I'll talk about antibiotic stewardship. This depends on 8 R's or 8 rights. That means the right drug should be given at the right time, at the right dose, through the right route, by the right nurse or the resident. There should be right documentation, and there should be a right reason for giving the antibiotic, and there should be a right response to the drug which is given. All units, whether it's a primary unit or a secondary unit or a tertiary level unit, should have or must have an antibiotic policy to say what are the primary antibiotics and when you would change the antibiotics, under what circumstances, etc. Antibiotics for newborn must be stopped as soon as it is possible, right? And downgrading of higher antibiotics to be done, coming down to more simpler antibiotics, must be done as soon as culture sensitivity reports are obtained. This possibly is one of the most important things for a neonatal nurse, preventing medication errors. When a prescription is written or a drug dosage written in the drug chart, always ensure that the name of the drug is written clearly, the dose of the drug is written clearly, the decimal is properly put in place, the route is also ensured and it's written very clearly whether it's intravenous or intramuscular or subcutaneous, and that the doctor gives a clear signature, which unfortunately doesn't happen very frequently. A very important principle is to avoid trailing zeros, that should read trailing zeros. That means a zero after a decimal point. For example, when you want to write 5 milligram, it's better to just write 5 milligram rather than 5.0 milligram. If the point is not written very well, the nurse will end up giving 50 milligrams instead of 5 milligram. And therefore, if there is a trailing zero after a point, do not put a zero, just write it as 5 milligram. But always you should use leading zeros. If you want to write 0.3 milligram, always make sure that the doctor writes 0.3 milligrams. Because again, if the point is not written very well, and if the zero is not written, the nurse will end up giving 3 milligrams instead of 0.0 milligram. Therefore, no trailing zeros, but always leading zeros. The date and time of the prescription should always be written. I always tell my nurses that a prescription should not be carried out unless the doctor writes the date and time along with the drug order. It is always advised that the unit should be written fully. Example, it's better to write milligram instead of mg, because if you want to, suppose sometimes when a doctor writes microgram, that is mu g, can be confused with milligram. I remember one instance in Australia where a nurse, instead of giving 1 microgram of fentanyl, actually ended up giving the baby 1 milligram because the doctor had written the mu like M. And therefore, the baby got 1,000 times the higher dose, and the baby actually had a respiratory arrest right in front of us. The weight of the baby should always be written in the drug chart. I should have mentioned that. And the nurse should always recheck the dose which is written and try to calculate and see, especially an experienced nurse, to see whether this dose is appropriate for that weight of the baby. Ensure that the drug is given to the right newborn, and before giving the drug, always recheck the baby's ID with the prescription or the drug chart. This again is a big principle in our nursery, and I'm sure in many of your nurseries. When you're using small doses or dilutions of drugs, the quantity has to be confirmed with another colleague before administration, right? This is especially so for those drugs where small differences in quantity like phenobarbital or morphine or pethidine makes a very great difference. Always minimize verbal orders. I know that in an emergency, doctors say, give this, give that. And we always try to write it after that, but always try to minimize these verbal orders. And whenever possible, tell the doctor to write the order before giving the drug. If there is an adverse event after a medication, it should be documented and informed to the superiors. similar looking different medicines. For example, we used to have 10% and 50% dextrose, which looked the same size of vials with the same color of um, the sticker. And nowadays, I think calcium gluconate and aminophyllin look very similar, and therefore they are not to be stored in the same cupboard, or they should be stored in different spaces. That is, look-alike and sound-alike medicines should be stored in different spaces. This will ensure that there is no medication error. A very important thing in newborn health is to prevent falls. Many studies have shown that fall of a newborn occurs more frequently, and this fall might be the mother or the caregiver dropping the baby or the nurse dropping the baby. Falls occur more frequently, especially by the caretakers after a cesarean section, during the second or the third post-op day, when the mother is on opioids and when the mother is breastfeeding. And there are certain principles to prevent falls. One, regular rounds by the staff to check that the mother, especially when she is breastfeeding, is sufficiently awake and is not very drowsy while holding the baby. Ensure that the mother gets adequate rest. In the nursery, always ensure when the baby is in a cradle that the side rails are always up, and the baby should not be left unattended. And the other thing is, if by some unfortunate incident the baby falls, there is something called a second victim. The mother or the caretaker or the nurse who actually dropped the baby is now actually vilified by everybody else, and therefore the family and the caretakers and the nurses need to be supported adequately. There are also various other injuries. Many of these would have been covered in the other topics: prevention of skin injury during IV line insertion, while putting a tourniquet, while attaching an adhesive, while attaching ET tubes, etc. Prevention of extravasation injuries and prevention of nasal septal injuries, and many other injuries which can occur during the course of the stay in the hospital of the newborn. How do we ensure that blood transfusions are safe in the newborn? Before you actually give a transfusion to the baby's ID must again be checked, and it must be ensured that this is the baby who requires the transfusion. The number of the blood bag should be cross-checked with the requisition or the tag which comes along with the blood bag to make sure that the correct tag for the correct baby has come with the correct blood bag from the blood bank. The parent's consent for blood transfusion must be documented. Check and document the baby's blood group and the blood bag group. Ensure that the blood product is correctly stored according to the guidelines given by the blood bank. Okay. Check that the blood or plasma after bringing to room temperature has no sediment, etc. before you actually start transfusing the blood product. And any adverse event after a transfusion must be documented in the appropriate form. Safe surgery. Errors during surgery can be because the wrong patient has been operated upon, the wrong side has been operated upon, the wrong level, that is the wrong portion of the correct part has been operated upon. How do we ensure that the newborn undergoes safe surgery? Ensure that all the documents are present and verify the baby's identification before you transfer the baby to the operating theater. Check that the parents have consented for the surgery and a proper consent form is available along with the documents of the baby before the baby is actually transferred. Before you do all this, confirm the details of the surgery with the neonatologist and the surgeon as to what the surgery actually entails. If there is a surgery on a part of a limb or on a limb, mark the site of the surgery. One of the principles is do not mark an X over the site which should not be operated. Only the site which needs to be operated has to be marked with an X or a mark, right? In the newborn period, because in most instances the newborn is away from the parent, always inform the parent and ensure that they accompany the newborn up to the theater. One of the most important things in ensuring that there are no errors during surgery is something called the timeout, where the operating team, that includes the surgeon, the nurses, and the anesthetist, again stops all the work that they are doing, and all of them together confirm that the correct patient has reached the theater, and they also confirm with each other about the site which is needed for surgery and the operation which is to be done. A very important technique or thing to ensure safe surgery is something called privileging, which unfortunately I don't think occurs very well in India. If a new procedure is going to be done, we have to ensure that the surgical team or the anesthetic team has the proper training for doing these new procedures, which is actually vital. So they should have both proper training or the proper experience for doing a new procedure. This ensures that the baby will be safe during surgery. We talked about the practices which contribute to patient safety, and now we'll talk briefly about the processes which contribute to patient safety. It should be ensured that the head of the nursing and the medical team of the neonatal unit are properly qualified to make decisions and to head the unit. Staffing should be adequate as per norms for each of the unit. Again, privileging. The nurse who's going to look after the newborn baby should have at least an adequate experience to move up to the levels of care, and she should be adequately trained before she looks after sicker babies or babies requiring intensive care. And this ensures the right person is doing the right job. You cannot start a junior nurse on day one looking after an intensive care baby. Prevention of fatigue and stress. It is well known that if there are shifts of more than 16 hours, the amount of errors increase many-fold. And therefore, it should be ensured that shifts are short and the staff and the doctors are not fatigued and they are not stressed before handling the baby. Periodic training has to be done, and this is not a one-time training, but it has to be recurrent training in hand hygiene, aseptic non-touch technique, fire safety, equipment cleaning, nursery housekeeping, etc. There has to be preventive maintenance and calibration of equipment to make sure that the equipment does not fail at the wrong time. And like I said, the hospital should have, especially in level 3 nurseries, should have CLAPSI, VAP bundles, etc. What is the best organizational culture for patient safety? All healthcare workers should accept responsibility for safety of themselves, their patients, visitors, and caregivers. The organization should prioritize safety above financial goals. It should encourage and reward identification, communication, resolution of safety issues, and not actually punish somebody who points out non-safe techniques or procedures. It should provide for organizational learning from accidents. This is something called Sentinel surveillance meetings. It should provide appropriate resources, structure, and accountability to maintain effective safety systems. I'll talk briefly. I think many of your hospitals should have something called Sentinel event reporting and audit. A Sentinel event is an incident that results in either death or permanent harm or severe temporary harm, and intervention is required to sustain life. But there are many such incidents or events which do not cause death or permanent harm. For example, in newborn, unanticipated death of a full-term infant, unanticipated asphyxia, discharge of an infant to the wrong family, abduction of a newborn, severe neonatal hyperbilirubinemia, etc. So all of these, there should be a system whereby anybody, including the junior most nurse or an intern or the junior doctor or the head of the unit or head of nursing, should be able to flag these events which are occurring during the stay of any baby. And there should be a system for anonymous reporting of sentinel events. There should be an audit of these events whereby a root cause analysis is is done of these events. It should be a no blame meeting, and fingers should not be pointed as to what went wrong, and the lessons learned during the Sentinel meeting are used to prevent recurrence of such events. Again, I'll talk about newborn infant abduction policy. Every hospital should have its own code pink policy. The purpose of the policy should be prevention of infant abduction and ensuring proper safety to newborn infants. It should facilitate speedy return of the infant to a place of safety, ensure that staff are able to effectively conduct or facilitate research and cooperate with security, ensure the staff are fully aware of each of their roles and responsibilities, and that parents are fully informed of the situation and appropriately supported. I'll just give you a small example of the code pink, which is almost similar to what we use in CMC. But like I said, this will not suit all systems. I think every single hospital should have their own code pink protocol according to their environment. So in CMC, we say the nurse who actually identifies that a baby is missing should inform the senior staff or the charge nurse or the consultant, who then will notify all the other staff in the unit. The security officer is called if the baby is not immediately found, and either the security or the nurse then blocks all the doors outlets from the nursery or the ward, and therefore secures the area to prevent anyone from leaving the ward. A head count is done immediately on all the mothers and babies in the nursery or the postnatal ward. If the baby is still not found, thoroughly check the department, all the areas, including the toilets and bins. Question the parents and visitors of the missing infants, and also the other parents and visitors who are present in the nursery or the ward at that time. The security officer will immediately go and stand at the building entrances, lifts, and staircases. All of us should look out for anyone acting suspiciously or carrying any package during this time. And nobody should be allowed during this process into the nursery except for authorized personnel. Any suspicious individual is not to be confronted, but actually to be followed, and then the security or the police to be informed. The incident has to be reported to the nursing superintendent and the medical superintendent, and a written incident report sent. This is later. They will then make a police complaint. The parents of the baby should be provided emotional support by the nurse and the attending doctor. How do we prevent newborn abduction? Staff should be educated on prevention policy and procedures. Like I previously emphasized, identification band for the newborn should always be attached to the baby. This is especially important because usually the baby is separated from the parents and parents do not stay with the baby, and therefore the identification band is one of the most important ways of ensuring that the baby is not misplaced. The infant should always be under direct supervision. Newborn babies should be transported only by authorized staff from the nursery to the ward or between departments. Examination of the baby should be allowed only by authorized doctors and staff who have a hospital ID card. Only the parents should be allowed to visit the baby in the neonatal unit. And in the postnatal ward, only a limited number of visitors carrying visitors pass, and only during visiting time should be allowed to visit the baby. At the time of discharge, before the mother and baby leave the hospital, a verification of the ID tags and of the mother and the baby should be done before they are allowed to leave the hospital premises. What is the nurse's role in safety? The nurse has to perform basic care and follow checklists. She has to learn from incidents and near misses. Nowadays, there is a lot of emphasis on electronic learning modules for neonatal resuscitation, training in procedures, and setting up ventilators, etc. The nurse has to be prepared and trained recurrently in fire safety, electrical safety, abduction policies, emergency evacuation procedures, etc. The nurse has to report adverse events so that they may not recur, and define the best processes and the safest distribution models for medication in the NICUs. And the nurse has to help in developing and testing various bundles of care in reducing adverse events. And in conclusion, like I said, ensuring newborn safety is not the task of an individual doctor or an individual nurse. We all have to work as a team to ensure that the baby leaves the newborn nursery safely. Safety as an outcome, again, is not a single road, but it needs multiple inputs. And this is ensured by training recurrently, by having protocols, by having guidelines, by having regular audits of adverse events and analysis of adverse events. There should be a no-blame culture in the organization, with the end goal being prevention of recurrence of such events. And with all these, we hope that the baby will reach home from the hospital safely. Thank you.